Hey, hello everyone. This is Sherry with the CGH Health Foundation, and thanks for tuning into our program. This is one of our Growing Healthier speaker series, and so in a moment, I'm going to turn it over to Dr. Bird, and he's going to be talking to Dr. Twinkle Singh, who is our newest interventional cardiologist. February is Heart Month, and so we always try to have a program that's focused on heart health. And so before I turn it over to Dr. Bird and Dr. Singh, I wanted to tell you a little bit about next month's program so you can look forward to that one. We will have Dr. Montegudo from the CGH Digestive Disease Department talking about everyday digestive health. And that program is going to be on March 23rd here on Facebook Live at noon. It is Heart Month, and one of the first events or recognitions that happens is the first Friday in February is kind of devoted to raising awareness for women's heart health. And so this Friday here at the hospital, we're all going to be wearing our red, and you can too, for the first Friday in February, Women's Heart Month, wear red day. And as long as we're talking about heart health, I did want to mention that I still have appointments available for this month's cholesterol screening. Every month we have a community cholesterol screening where we check your cholesterol numbers and your triglycerides and your blood sugar. And if you would like to sign up for that screening, you can call me, just the hospital number, and ask for me at extension 5716. And with that, I will go ahead and turn it over to Dr. Bird and his interview with Dr. Singh.
Thank you, Sherry. Nice job. So welcome everybody to Facebook Live. This is Dr. Bill Bird, CMO here, Chief Medical Officer at CGH Medical Center. Thanks for joining us today or joining us at some point in time in the future. Yeah, today we're going to be talking with Dr. Twinkle Singh, who is one of our interventional cardiologists here at CGH. And we're going to talk about heart stuff. So with no further ado, let's get Dr. Singh here on our Facebook Live. Hi, Dr. Singh.
Hi, thank you for inviting me.
Well, you know I'm going to invite you. Every once in a while we're going to reach out and say, hey, Dr. Singh, let's talk a little bit. So
this is good,
today's your lucky day.
Yeah.
For those folks who haven't had a chance, aren't aware of Dr. Singh has been at CGH since what, August?
Mid-August, yeah.
Yeah, okay. And Dr. Singh has hit the ground running. She is a very busy woman, does a lot of good work here at CGH and does very good work with patients. And I'm not just blowing smoke, folks, but Dr. Singh already has an excellent reputation here at CGH for the care that she gives to our patients and the work that she does. So Dr. Singh, thank you already after just being here a few months for the work that you're doing.
I'm glad to be here.
So let's jump into some questions. And obviously the promo is talking about procedures we can do in the hospital here to help people who have heart issues. But I thought before we started talking about patients that we can help with heart issues, maybe we could start talking about what people can do to keep themselves off of the cath lab table. So let me just throw out the first question being to you, Dr. Singh. What are the latest recommendations about what folks can do to prevent heart disease in the first place?
Okay. So prevention, it starts as early in your life as possible. And of course, the lifestyle has a very major role to play in it. Your diet and exercise. Okay, diet. Everybody pretty much knows exactly what is healthy diet and not. But just to reiterate that, if your diet is full of vegetables, fruits, nuts, whole grains, and stuff like that, and seafood like fish, and as long as you're avoiding, processed food, essentially, avoiding red meat or anything like refined carbohydrates or even sweet beverages. So if you're avoiding those things and you're keeping your diet full of like good stuff, that will go a long way. Secondly, exercise, yes, and you don't have to be like an athlete to offset your cardiovascular risk over your lifetime. It's just very like I tell my patients, like moderate intensity exercise, meaning just brisk walking, like 20-30 minutes a day, and total of like the recommendation is 150 minutes per week, but 15-20 minutes a day, just brisk walking, just the regular things that you do, gardening and stuff like that, even dancing or water aerobics and stuff like that, like very moderate intensity exercise that will help you definitely decrease your risk of developing major cardiovascular diseases down the road. And everyone knows this, and smoking is a big no-no, and not just for your heart health but overall. And controlling your blood pressure and controlling your cholesterol level, so, and working with your physicians on a regular basis to make sure your risk factors are controlled, that will definitely keep you off the cath table.
Do you have any particular dances that you would recommend, Dr. Singh?
No, whatever you like.
How about for yourself? What would you say that you would do if you were to dance?
Oh my God.
I'll give you a pass on that
Like,
one.
no, I'm not a dancer.
All right.
There's some people like to, and that's like a fun activity. And
Oh yeah,
yeah,
I'm with you. Yeah. Okay. You mentioned high blood pressure and high cholesterol. So, what are the recommendations in terms of blood pressure and cholesterol that people should be thinking about in terms of controlling to reduce their risk of heart disease?
Yes. So blood pressure, controlling your blood pressure, I mean, it also depends on what other medical conditions you have. Okay, so if your recommendation is that your blood pressure should be less than 130/80, okay, not just like if you have like one or two readings above that, that's not what it is. But if it's your pressure is consistently above 130, that will qualify as you as having hypertension or high blood pressure. But what to do from there onwards, it depends on what other comorbidities you have, like if you're a diabetic, if you have renal disease or high cholesterol, or family history, you smoke, all those risk factors. At that point, then it is advisable that you start on medications to make sure your blood pressure remain controlled. But if you're a healthy individual, lifestyle modification is definitely the first thing that just diet and exercise that we talked about will and if you do it religiously and consistently, that will definitely help you control your blood pressure. And other things like treating your sleep apnea, that definitely, losing weight, if you that's one of the most effective way of controlling your blood pressure. And do you have anything to add, Dr. Bird, to that?
I was just wondering, like, do you are there any different recommendations for blood pressure control for people who are getting older?
Yeah, I mean, as you get older, like a lenient blood pressure is still okay. But still, even in octogenarians, like even in 80 years old, if your blood pressure is controlled, that definitely benefits them.
Do you define control as still 130 if you're, let's say, 80, or is it more like 140? Or
More like 140.
okay.
Yeah.
How about cholesterol? What would your you see that comment from Jordan? That was very nice. Yeah.
Yes.
How about cholesterol? What would you say about, like, what should folks be thinking about with cholesterol?
So the cholesterol, I mean, again, it depends on a lot of factors. It depends on if you've had a heart attack before or if you're a completely healthy individual. So let's say if you're a completely healthy individual, your cholesterol, the number we look at, LDL, is one of the component of your total cholesterol profile, lipid profile. It should be less than 190 milligram per deciliter, and as low as possible is good. And if you don't have any other comorbidities, you don't have any other disease, you don't have any family history or smoking or anything like that, then you can work on your cholesterol just based on your lifestyle modification, like with good diet and exercise. Your Whenever you go see your physician will work with you, and they'll define like how much risk you have of developing future cardiovascular disease based on your cholesterol and based on the other factors. So if your risk is higher, then they may want to start you on medications. But if your risk is lower, then you can just be treated with lifestyle modification. The secondly, if you have had an event in your life like a heart attack or a stroke, or you have peripheral arterial disease, those conditions will put you in the category that we have to make sure your cholesterol is good as a secondary prevention, meaning that you don't have those events again. So in that cases, like, recommendation is that your LDL should be at least less than 70. Okay. And we most of the time we put patients on statins, and if the statins are not able to control those cholesterol levels, then we can add other medications to it. And we have, like, now we have so much more advanced, like, injections like Repatha and Lequio. It is the new medicines. So so we have a lot of options. So but yeah, less than 70 and as low as possible, that is the recommendations as of now.
Very good. Very good. Some people kind of fall in that middle category of their risk factors, or they may have a family history. And we have it here at the hospital. You can actually do what's called a CT scan where they
Yes.
get a calcium score.
Yeah.
Tell you where your calcium score is.
Mhm.
What people are a good fit
Yeah.
to do that, would you say,
Yeah.
Dr. Singh?
Yeah, that's a really good thing to talk about. And so cardiac calcium score, it's like essentially a CT scan, and it detects the amount of calcium that is in your arteries. Okay, the higher amount of calcium definitely puts you at a higher risk of developing future cardiovascular events. So the people the cardiac CT is good for is usually the middle age group people, like, usually, and they are at moderate risk, but they're not very symptomatic. Because if you're symptomatic, then you should go for a stress test. But if you're not symptomatic and your risk is not extremely low, but you, like, let's say you're a completely healthy person, 50 year old, and but you smoke, or you have family history of heart disease, or you have high blood pressure, then you will be a perfect candidate to get that test. So yeah, so moderate risk individuals who are, and even if you're mildly symptomatic, that's fine too, because most of the time we don't really know if your symptoms are coming from your heart, or it could be something else as well. Yeah.
So the bucket of people that are not a good fit is if you clearly already have heart disease.
Yes.
You don't need that, because we already know that you have calcium.
Yes.
And secondly, if you are like stone cold healthy,
Yeah.
there's no family history,
Yeah.
your cholesterol is perfect, your blood pressure is perfect.
Yes.
Don't worry about it doing that test.
Yeah, and that test will also actually help you determine that if you need to be on some medication therapy for your, let's say, for your cholesterol. Okay, so even if you have a high score but you don't have any symptoms, then and you're, I mean, that can determine that if you should be on a cholesterol medication.
Yeah.
Yeah.
And would you put someone at moderate risk if they have that they fit the category for definition of obesity?
Say that again.
Would you put someone in the moderate risk category who should get a scan if they're
I would.
Okay.
Yes.
Okay.
Yes.
Okay. Just yeah, and this one's putting the heart check down there, but yeah, that's just something for people to be aware of. Sometimes we don't think we're high risk, but you can act if you're way more than you should. If your body mass index is above 30, you would still fit in that category. So
Absolutely.
okay, great.
Yes.
Yep.
Obesity is definitely a risk.
Okay.
Yeah.
One last question about just symptoms of heart disease before we actually get into some of the techniques and procedures that you do, Dr. Singh. So I think most people know heart disease wise some pretty typical symptoms like crushing chest pain, radiation into your jaw, sweating, those kind of things. Would you just mention also some like unusual or atypical kind of symptoms that you've seen patients have that actually have heart disease?
Yes, absolutely. So, I mean, women and even diabetic patients, they present with atypical symptoms all the time, especially women. You can be short of breath. Okay, you can feel drained. Pain doesn't necessarily have to be in your chest, it can be in your shoulders. Sometimes patient will have like neck pain or jaw pain. Most of the time it is exertional, but again, with women it can be, even at rest, You can have sometimes you can have pain, but as you walk and your pain might get better. That also happens in certain type of blockages. You can have like, you feel dizzy, lightheaded, or you just feel like you're not able to do as much as you used to be able to do. You're just feeling like fatigued. That itself can be a symptom of heart disease. Sometimes sweats, like cold sweats at night, or even during the daytime, that can be a indication of a heart disease as well.
I typically have thought about with patients that if they have like sharp, really like brief, sharp chest pain, that's typically not their heart. Is that different for women? If they have that kind of chest pain, would you still consider them someone you would want to get more of a workup on?
For women, it can just like not just be the CAD, because you can have pain from spasm, you can have pain from microvascular disease or microvascular spasm that not necessarily is exertional. So for women, I think you have to look at everything. You have to look at their risk factors, like how much risk are they at of developing heart disease.
Okay. Yeah.
So I would definitely consider at least screening them. If they have some kind of like concerning symptoms, I would consider screening them for
Yeah.
existing CAD. Yeah. Or at least presume that they have CAD, and just treat them with medications.
Yeah.
Yeah.
Okay. Thanks for your kind words there, Kay. So okay, let's go down the path now of, all right, you've done everything you can do. You've tried your best, but you know what? You end up and you need to have an angiogram and perhaps even have some sort of intervention done to help blood flow in your heart. So what I'd like you to do, Dr. Singh, is, this is obviously your area of expertise. Tell us about, if someone has a blockage in their blood vessels, what are some of the latest techniques and technology that CGH has that you perform to help open up those blood vessels?
Yes. So just to tell, the basic thing is that the way you open a blockage is you put a wire through a blockage and you open up with a balloon, essentially. Like you balloon the blockage from inside, and then you put a stent to keep it open. So it works for blockages which are simple. Okay, but most of the time, and especially as you get older, if your blockages have like a lot of calcium in it, then balloon itself might not be enough to open it up. Okay, and if you put a stent in an unopened blockage, then that stent will most likely close very sooner than later. So typically these type of blockages that have lot of calcium, they are usually dealt at higher centers. But here at CGH now, we have I have been doing shockwave, which is a specialized balloon. It's a really good technique. It's very simple to do. It's a balloon, but it sends the shock waves through the calcium and cracks the calcium. And that way, once the calcium is cracked, your blockage can be opened up with a regular balloon after that, and your stent will remain open. Second thing we've been doing is it's called atherectomy, CSI. It's a burr. It goes over a wire. It's a burr, and it shaves off the calcium from inside of the artery and helps opening that blockage.
Well, it's a burr that just kind of
rotates inside the artery, and it's like shaves off the calcium.
Like a rotor-rooter for your artery.
Yeah, but it's not exactly like rotor-rooter, in the same category, and that's something that we don't have. And that also works. Rotor-rooter is actually.
Well, our maintenance department has a rotor-rooter, I'm sure, but our maintenance department probably has a rotor-rooter, but probably not in the cath lab, right?
Yeah. And other thing is, I wanted to say that we have like imaging. We have good imaging modalities. Like we can do like an ultrasound from inside the artery and exactly define what kind of blockage it is and how it should be treated. And we've been doing a lot of that as well. And other thing that we recently acquired is penumbra. It's a thrombectomy catheter, and it can be used especially if somebody just had a massive heart attack and if that artery is full of clot. So sometimes clot can be small, and sometimes people can have like a lot of clot burden. And if you have a lot of clot burden, then just a stent might not be enough, because the clot has nowhere else to go. It's just going to sit in the artery. So this penumbra catheter is very good in patients, so like we can go it inside and suck the clot out and just remove the clot from the artery. Okay. So that's very new to our cath lab, and it works not just for the heart attacks. It also works if you have clots in your lungs, like if your clots travels from your legs to your lungs, and we have been doing those cases as well. So yes. So those are the main things. And then there are some balloons and extra balloons and everything that we have acquired that
Yeah.
are specialized. Yes.
Do you use any ultrasound, like to visualize things or anything like that, Dr. Singh?
Ultrasound, like for access, or yeah. So we like I mentioned that we have imaging modalities. It's called intravascular ultrasound. It is a ultrasound catheter that you can use to visualize the artery from inside. So we do use that quite a lot.
Okay.
Yes.
And that kind of helps. Does that help you decide which one of these modalities you're gonna
Yes.
go with?
100%, yes, because that defines that tells us exactly how much calcium is there, or if that calcium is going to respond to just balloon, or if you do need some kind of atherectomy device to deal with that. So that definitely
Right.
helps us. That helps us decide the size of the stent, length of the stent. So it gives us a lot of information.
Yeah, good. Good, thanks. There was Rebecca, would you put up that question? So there was the question, Dr. Singh. Would you want to take a crack at that?
Yes. Okay. So the question is, with heart disease being in a family history, can tests be scheduled before problems show up? Absolutely. Yes. Yes. That patient, that kind of a patient will is a good candidate for that cardiac CT, because if your calcium score is 0 or less than, even less than 100, then your risk is low, and you don't. And but if it's much higher, then that tells us that you're at a high risk of developing some cardiovascular disease, and we may or may not have to talk about starting you on some pharmacotherapy like statins. So yeah.
Okay.
Yeah.
So what Mary's talking about there, that question, that kind of still, it falls into that moderate risk category that we were talking about for that
Yes.
cardiac CT.
Yes.
Good. Very good.
Yeah.
All right. I think you kind of hit at this, but let me just make sure we're clear on this. So how would you say, like, the resources and technology that you have access to here at CGH compared to like bigger centers?
Technologies that we have, they're essentially it's a standardized equipment. It's the same that we have here and at the higher centers. I mean, there are certain things that we don't have, like we don't have the rotational atherectomy, which is also another modality to deal with the calcium inside the artery, but it's used in like a much higher risk patients. And I think the biggest thing that sorry about that, the biggest thing that I think is different from us and differentiates us from higher centers is the availability of a cardiothoracic surgery backup. So that precludes us from doing like much higher risk cases, because we don't have a CT surgery backup. And in that case, like, we refer those patients, we do what we can here, and we refer those patients out to higher centers. And certain things, like we don't do valves, we don't have a structural program that deals with valve interventions, we don't have that. And we don't have like advanced cardiac support system, like we don't have impella, we don't have ECMO or mechanical circulatory support that can be used in patients whose heart is just like is in shock because of a heart attack. But we recognize those patients early, and we do what we can, and then we transfer them out on a timely basis.
Yeah, I think what I just want to make sure for the folks who are watching this, just to be aware of that, we do a lot of stuff, a lot of opportunities that we can just take care of things here.
Yes.
But Dr. Singh and Dr. Kiso are also really attuned to what we don't have. And if they feel like a patient is someone who's not a fit, then we'll get that patient where they need to go.
And I want to re-emphasize that I think those atherectomy and the shockwave, that has allowed us to do much more than we used to do before. So because dealing with a very calcified blockage, it's difficult. It's not the easiest thing to do. And these new devices and equipment, they have definitely allowed us to take care of those those kind of cases. Used to be we refer them out, but now we have this equipment, so we can do them here. Yeah,
very good. And there are other blood vessels that you also take care of, Dr. Singh. I know you do. You did a fellowship also to take care of people who have blockages in their leg blood vessels.
Yes.
So can you talk a little bit about what you do to help patients out who have blockages in their legs?
Yeah, so it's so once you are like at a higher risk of developing heart disease, it's the same disease process, essentially the same disease process everywhere else in the body. That includes the blockages in your neck or blockages in your arteries of your legs, or sometimes arteries, even the blood supply, arteries that supply blood to your arm. So we do deal with those blockages as well, mostly. But the patients that qualify for those kind of interventions will be the patients who have like a lot of leg pain when they walk. And we have tried everything else, like we have tried exercise and we have maximized their medications, we have controlled their risk factors, and despite that they continue to have pain, and it is definitely, affecting their quality of life. Then those are the patients that we can definitely help, and we have very good equipment for that here as well. So yeah, and some we can deal with vein, especially with our vascular surgery department. We also deal with vein problems. Like if you have damaged veins in your legs, then that can lead to like swelling or some varicose veins. So we can take care of that kind of patient population as well.
Yeah, very good. So yeah, so between Dr. King and yourself, we have
Yeah.
definitely have some things that we can do help folks out. And yeah, so keep in mind, if you're somebody who you walk and all of a sudden you get pain in your legs or a leg and you can't go any further and you have to rest and then go again, that could be a sign that you have narrowing in the blood vessels in your legs. And doctors like Dr. Singh and Dr. King are oftentimes able to improve those symptoms by opening those blood vessels up. So
yes, absolutely.
How soon after you have like one of the procedures that you were talking about, and I know sometimes you're different. We're talking sometimes it's stable people who have symptoms, like they just have ongoing symptoms, and you open them up, and sometimes people you're opening up are in the middle of a heart attack. But can you kind of speak to how soon after someone's had one of these procedures done to open up blood vessels that they're able to go back to normal activity?
Yes. So not long, actually, not at all. Very long. Usually, patients are very much functional the next day. The only thing that we ask them is to not do a whole lot for like next 4 to 5 days, like not lift heavy things, and not like climb 100 stairs. But usually, like daily house routine, daily chores, and daily routine activities, they can resume like within next 1 to 2 days. And that is true for like even with patients with heart attacks or patients with stable symptoms. So once they are stable enough to go home, usually the recovery period is nothing. And cardiac rehab is something that helps tremendously in getting back patients to their previous quality of life.
Yeah, you mentioned cardiac rehab. So we have that here at the hospital. It's actually out on Lynn Boulevard in the basement is where we have cardiac rehab. How soon do you get patients into cardiac rehab, and who are the patients that you tend to send there?
Yes. So cardiac rehab is actually very useful for almost all kinds of heart problems. Okay. If you have coronary artery disease, if you had a heart attack, you have heart failure, you have any valve issues and you've had valve intervention, or even after the cardio like bypass surgery. So all these patients will qualify to go to cardiac rehab. And I think I think getting into the cardiac rehab has not been that big of a time difference. Like once we refer them, they usually get into the cardiac rehab pretty soon.
So if you've had a heart attack, we're talking about getting you into cardiac rehab within a week or two after you've had.
Yes, within a week or two.
Okay. All right. Yeah. Good. Mary was asking, are there any tests that can be done to find out if someone has had a heart attack in the past?
Okay. Yeah, I mean, there's stress tests will tell you that. So like nuclear medicine tests, they will tell you if there is a lot of things can tell you that. Nuclear medicine test will tell you if there is a part of heart muscle that is not getting enough blood flow at all. So that will be an indication that that patient might have had a heart attack in the past. EKGs, your EKG, certain things that you can, certain patterns you can see on your EKG that are indicative of that. Even the ultrasound, which is an echocardiogram, it will can tell you that, like if some part of your heart muscle is not moving as well as the other part of your heart muscles, then that will be an indication. And the sure test, 100% sure test that you've had a heart attack in the past is cardiac MRI will tell you. These are all the non-invasive, I'm talking about non-invasive modalities. So yeah, cardiac MRI will tell you, like, if you've had a heart attack, you have any other kind of heart muscle disease, or your heart muscle was affected because of an infection or an autoimmune disease, or so yeah, that's
Yeah.
probably the best test. But yeah, we don't have that here, but we have had patients referred for cardiac MRI outside.
Most of the time, my experience has been, though, that you can get a pretty good idea between your EKGs and your echocardiograms and
Yes.
stress test. If there's like this area that fits with the EKG on an echo, that's, oh yeah, that part of the patient's heart fits with the EKG. It's not pumping well. Well, you feel pretty comfortable, I would think, most of the time, saying, yeah, there's something happened there.
Yeah.
Okay.
Agree. Yep.
I know we're kind of getting short on time here, but I know sometimes it can be frustrating for folks to get into specialists, and if they have a heart concern and stuff like that. Can you speak a little bit with your department where we're at in terms of having patients having the availability to get in to be seen for a heart-related concern?
Yes. So once our department gets the referral, like our schedulers, once they get the referral, so I can't really speak to the time difference between a physician decides to refer you to cardiologist and the time difference between that to actually making the referral. But once the department gets the referral, the getting an appointment is not long at all. Anywhere between 5 days to 2 weeks, we can get you in.
Very good.
We actually looked into that, and the mean was, and that was only for the particular month. The mean was actually 4 days that the referral, and within 4 days the patients were able to get in.
Yeah. So I wanted folks just to be aware of that, because I know we've had, just to be transparent, we've had issues in the past where it took a while to get in, but we've really improved the bond.
That is not an issue at all. And like me and Dr. Kiso, both of us, and our like excellent nurse practitioner team, like we can even increase our clinic slots if need be. So getting patients in the clinic is not, it's not, that shouldn't be an issue.
Perfect.
Yes.
So, and we talked about clinic and hospital, and I was wondering, any kudos you want to give to your teams that you work with, Dr. Singh?
Yeah, absolutely 100%. Like my cath lab team, they are the best cath lab team that I've worked for. And one thing, they're all, no offense to you, but they're all females, and they do great. Chico, except for Chico, who's our cath lab manager.
Okay, all right. You put up with Chico, but otherwise you have women to work with, right?
They're amazing. They're amazing. And even our the clinic, our nurses, they are so efficient. They're so great at making things happen so quickly, getting the test scheduled. It's a lot of work that goes into getting a patient seen and actually setting them up for a procedure or for a test, and they take care of everything so efficiently. And our nurse practitioners, they have been here for so long, and they're so experienced. So I trust their judgment completely. So I mean, I really like essentially everyone that I work with here.
Dr. Singh, it's great to have you on.
Yeah.
Appreciate your time, appreciate your expertise, and for the folks out there that are watching, Dr. Singh is she's the real deal, doing really good things for patients here at CGH, and we're glad to have her. Dr. Singh, thank you so much.
Thank you. No, thank you, Dr. Bird.
Yeah, all right, take care.
Yes. All right.
All right. So I hope you found that interview helpful. Dr. Singh is great. So great to have her on. Hey, I don't have a whole lot else I want to share other than, we talk a little bit of pandemic and things are in terms of the government and health emergency. It sounds like that's around May that we're going to be going away from that. So that's good. We still are having some cases, so be smart. And the main smart thing I would say is, if you haven't gotten fully vaccinated, just make sure to do that. Particularly if you're someone who's like my age and older, to make sure you're fully vaccinated, because the data continues to flow in. The folks that are getting their vaccines, there is definitely some protection related to really getting really, really sick with COVID, and who wants to get really, really sick, right? So anyhow, just wanted to make that as a recommendation to continue. Other than that, I wanted to show a few other things, some things to talk about. So we wanted to give Heather Hegeman a shout out for getting the Daisy Award for extraordinary nurses. Heather works down in the downtown clinic. So the top level there where Dr. Blasquez and Christina Miller and Julie Wardell and others are at up there. So thank you, Heather, for all the good work you do there. And our Sunshine Award to Kathleen. Kathleen is a huck on the surgical floor. And you see Kathleen's shirt there underneath her medical grays. She typically, her shirts match her shoes. So she's very, she does a great job, and she's kind of fun that way too. So shout out to Kathleen. And heart check. So we talked about that during our broadcast today, and that is $99. If you wanted to have that scheduled, you can actually just call and get that scheduled for yourself. It's kind of like mammograms. So once again, if you're in that moderate risk category, something to consider. Oh, and then I wanted to just talk about what we're going to talk about. So February 16th at noon, we're going to have on from top to bottom there, Pam Catt, Morgan Jacobs, and Lindsay McBride, and we're going to talk about pelvic health. So these are our folks that are in our rehabilitation department who work with people who have pelvic floor and perinatal kind of physical therapy issues. So a lot of women's related pelvic issues, but there are a few men's issues as well that we probably will touch on. So looking forward to having them, because they a lot of good information and do a lot of really interesting stuff that I'd encourage you to pop in on and take a listen to. Okay. Other than that, I think I've taken enough of your time today. I thank you for taking the time to watch this and being part of this broadcast, and encourage you to share it with others if you found it helpful. Until next time, thanks for watching, and we'll see you soon. Bye.